of the oldest and the largest global organization, which has around 1.3 million medical students as a part of its organization. We have various focus areas which we usually work on. We have the international student exchange programs, along with external opportunities, along with the workshops and the training sessions, capacity building events. We have the National Assembly, that's National General Assembly, along with the National Workshop Meet, along with health camps and a few others. So with that, we also have the 6 standing committees, one being the Standing Committee on the Sexual and Reproductive Health, including the STDs, which Shivani will be speaking more about. Shivani.
Thank you, Neil. Good evening, everyone. I am Shivani Nirgudkar, the National Officer for the term 2022-2023 for SCORA, which is one of the 6 standing committees that Neil was talking about. I hope I'm audible at this point.
Yes, loud and clear.
All right. Thank you. So the Standing Committee on Sexual and Reproductive Health and Rights, including HIV and AIDS, which is SCORA, is one of the 6 committees that MSAI comprises. It helps in advocacy and for helping marginalized communities realizing sexual and reproductive health and rights. It helps in advocacy for a safer, more sex-positive future, and it helps medical students play their part in becoming part of such a large movement, which is directed for the generations to come. I think one of the focus areas, so we have 5 focus areas in the committee that we work on. Gender-based violence, maternal health and access to safe abortion, HIV and other STIs, comprehensive sexuality education, and sexuality and gender identity. So today, as we all know, we've gathered here for Breast Cancer, A Journey, which is the title of the webinar. The reason we have gathered here is because October is celebrated as Breast Cancer Awareness Month.
Shivani, you're not audible now. You're on mute.
Oh, I'm so sorry. I'm so sorry. All right. Am I audible? Okay, perfect. Thank you. So, breast cancer is one of the most commonly occurring cancers in women. And that is not to say that it is limited to women. We are here to generate awareness about the same. It has a prevalence rate of about 14%, which is massive. And most of the cases that lead to further complications and even death are due to lack of awareness, lack of screening facilities, and then subsequent late diagnosis. We have today with us a webinar that is awareness regarding the part that medical students can play for the same. And with that, we'd like to welcome our guest of honor for today, Dr. Samita Bhardwaj. Dr. Bhardwaj is a consultant gynecologist and a national program manager at the Federation of Obstetrics and Gynecological Societies of India for Manyata, a project which aims to reduce maternal mortality and morbidity by improving quality of maternity services through private sector intervention. She's a medical graduate with a postgraduate diploma in gynecology and obstetrics and hospital management. That is to say, she's completed her PGDHA degree, and she's conceptualized and managed several service delivery facilities of and quality assurance at reproductive and family planning centers. She has worked on implementing policies, developing strategies, and executing projects involving medical training and quality of care protocols on clinical services in 15 clinics, infection prevention practices, and training of service providers. Dr. Bhardwaj, we'd like to thank you for taking out your time and gracing our webinar to help us become more aware medical students. So with that, we'd like to welcome you to the webinar. I think you could take it from here, if that's okay.
Yeah, thanks, Shivani. Thank you, Neil, for inviting me for this. This is like my first such session for medical students, so I'm very, very happy and thrilled to be part of this particular webinar. Okay, so I think one thing that we all should do is that make this webinar more interactive. So instead of just having theory and slides, etc., let's talk one-to-one. You all can ask some questions if there is something in your mind. You know, as I run through the slides, we can talk to each other. Let's keep it interactive. Anybody who is comfortable putting the video on can do so that, you know, I can then maybe talk to that person. Right now, I see Shivani and Neil was there. So, okay. So my topic for today is to talk on breast cancer screening. So I hope that this is visible to all of you. My screen is visible, right?
Hello, ma'am. Good evening. Hi, this is Anagha. I'm one of the national officers of SCORA. So sorry to disturb you. Can you put your presentation in the screen presentation mode?
You know, that was a technical challenge that I just
Go to
faced.
view, ma'am. View next
Is
to
it?
the home button.
Can you not see it properly?
We can, ma'am, but if it's in the other mode, it would be great.
No,
You can
but
go to
I
view
have some issue with the I faced some issue. My other laptop just conked off. So I actually had to take help from my daughter to put this on in the last 5 minutes. So we'll have to make do with this. Sorry for this.
No,
Yeah.
no worries, ma'am.
Okay, beta. So my topic is on breast cancer screening, right? And yeah, 1 second. Okay, so the little bit theory I have put in the beginning of the presentation just to kickstart. You know, we all are, I'm sure you all are first year, third year, fourth year, third year, must be all your students, right? And so we all know that breast cancer is the malignancy of the breast tissue. Starts in any part of the breast, spreads to surrounding tissue and can spread to any part of the body. It starts in the lobule or in the ducts of the breast. And as are all other cancers, rapidly dividing undifferentiated cancer cells are there which metastasize. Correct. So how common is this cancer now? It is very, very significant cancer. You know, earlier if we made a list of, you know, the commonest cancer, cervical cancer would take precedence. But now that somehow is coming as number 2. And breast cancer, you know, not just in the affluent countries, but even in our country, it's now as number 1 cancer in the reproductive age group. So anybody who wants to tell me how much is the occurrence of breast cancer? Shivani did mention it in the beginning. Right. So the incidence is around 14%. It was in 2018. And now we see that there is an increase in the incidence of breast cancer. It's gone up to 27.7%. And as breast cancer cases are going up, cervical cancer cases and other cancers are kind of, staying at the same level because there are other strategies that are coming out. So you all are aware for cervical cancer, there is a vaccine that is available for adolescents. Cervarix, Gardasil. So all those various initiatives that have been started. Because of that, cervical cancer is now taken like a second spot, and breast cancer is the number 1 cancer in the reproductive age group. And so it is one of the 2 leading causes of deaths in women, not only in India, but across the globe. And as we just said, cervical cancer was number 1 killer. But over last 2 decades, the scene is changing. And because of the vaccine, because of other strategies, you know, including pap smear examination and public awareness that's been done, the other cancers are kind of stationary, but breast cancer is on the rise. Right. So across the world that has been observed. And so we are a federation of gynecologists. And so within our federation, we have taken up to us to ensure that basic screening of each and every woman is done. I will tell you all what screening methods are there. But as gynacs, because we deal with deliveries and labor, etc. Sorry. We also see a lot of benign breast diseases, lactational issues, etc., breast engorgement, breast abscess, you know, all of those. So gynacs have a clear-cut hand in making sure that the basic awareness about breast cancer is there in the general population. So to accomplish this, there are certain guidelines that have come out, which tells us how do we integrate this basic teaching in even postgraduate curriculum. And it should be applied across India as well, because women generally prefer to go to gynecologists for their breast issues rather than to a surgeon. So initial diagnosis, initial detection can easily be done by gynecologists. And we have to treat cancer, this breast cancer, as gynecologist domain, because we are dealing simultaneously with other pregnancy and lactation related issues. So as far as we are concerned, we can call ourselves as preventive oncologists for breast cancer. A bit on the anatomy. So we all know that normal breast, and these are the lobules and the ducts. Lobules are the milk producing glands, ducts carry milk to the nipples, and there's stroma tissue which is surrounding lobules and ducts. So the muscle side view of the breast is how it looks like. And these are the lymphatic system or the lymphatic drainage. And we all know that when metastasis happens, the drainage system helps the cancer to spread rapidly. Now, this cancer is highly dependent on hormones. These are hormone-dependent cancers. Which are the two hormones in the playing a major role in the woman's body? Anybody wants to say? Anagha? So, because I can see you. Yeah. So
There are, I'm so sorry, ma'am. No, I'm just waiting for some responses from the audience.
Yeah.
So a lot of them are saying estrogen and progesterone.
Oh, wow. That's so great. And so which year students are you all? I mean, today I can see 100 plus.
They're from first year to interns, ma'am.
Okay. Right. So they're so right. And rightly they're saying that estrogen and progesterone play a major role in a woman's body right from the time of menarche till menopause. So from menarche, the first time that the girl bleeds, till menopause, the estrogen progesterone related are due to this estrogen progesterone, we have all the gynec related issues. And all of this estrogen progesterone works through one system, which is the HPO axis, the hypothalamus pituitary ovarian axis. And all of that occurs because of the changes in the HPO axis. Right. And what we have to remember about breast cancer is that this cancer is heavily estrogen and progesterone dependent. So that is the point that I want to make here. So this is so far the basic anatomy and the basic information on breast cancer. But coming to the topic of relevance today is how do we screen? How do we screen a woman for breast cancer? So there are three types of screening that I want to talk. One, the number one screening is the risk screening. Risk screening is we want to assess whether the risk of a cancer is high or low for this particular woman. So that is the risk screening. So I'll show you certain points which says that if you have this, then you are at a high risk. Whereas if you don't have this, and you're this, then you are at a lower risk of getting breast cancer. That is the risk screening. Then we will come to the breast screening. How do you do the screening for the breast? And then the third thing, which is now coming up in a big way, is the genetic screening. So these are the different methods of screening for breast cancer. Okay, before I go to the next slide, so what do you think, in which patient, in which gender will we find more of breast cancer cases? Or which sex will we find more of breast cancer cases?
Females.
Yeah, I think Monica is trying to say something. So obviously breast cancer cases will be seen more in females, right? So being female is number one high risk. Age-wise, what do you think? What age would be most likely to be affected? So, because I said it is highly estrogen and progesterone dependent. So, if a woman has got, a longer duration of exposure to these two hormones, and that will happen if she's got an early menarche and a late menopause, right? If she's got an early menarche and a late menopause, then estrogen and progesterone has been in her body for a longer duration. So longer the duration of exposure to estrogen progesterone, higher the risk for the woman to get breast cancer. So that is also very important. In Western countries, we see it after the age of 50, but in Indian women, we're also seeing it beyond age of 40. So two factors that we already saw, and that shows us that these are the high risk patients. Age-wise incidence, if you see, by age 20, the incidence is 1 out of 1600 or 1600 plus. But if you see by age 50, it is 1 out of 45, right? And a lifetime risk of a woman to get a breast cancer is as high as 1 out of 8. So when you will start practicing very soon, you all will do your PG, start practicing, you'll see that breast cancer is so common that 1 out of 8 women are at a high risk of getting the cancer, breast cancer. Now, what is the fourth screening point? The fourth is if there is a family history. History में पूछते हैं ना, family history of hypertension, diabetes, bronchial asthma, this, that, and all. So even in this, if there is a family history, then the woman's chance of getting breast cancer is about 12 to 15%. And we've also seen that 5 to 10% breast cancer cases are hereditary in nature. And they result from mutation in genes, and two particular genes that are of importance, BRCA1 and BRCA2, right? So this is the fourth factor where you can see if the woman is at a higher risk or no. If we say family history, then what would you say? Family history in who? Maternal side or paternal side? Anybody? किसमें फैमिली हिस्ट्री पूछेंगे कि आपकी बहन को है, मम्मी को है, या योर मदर इन लॉ, व्हाटएवर, लाइक द व्हाट विल यू आस्क? और द पैटर्नल साइड,
the responses say maternal.
Maternal, absolutely right. So that you should remember that if her sister, her mother in the family. How are you able to hear responses, Anaga? I can't hear. You're seeing the responses, is it?
Yes, ma'am. I'm just reading them out from the chat.
Oh, okay. Great. You're the spokesperson. Then you keep telling me what people are saying.
Sure.
Okay, very nice. Okay. Now also it depends on the number of children that a woman has over her lifetime. If she's a nulliparous, no children, then she's at the highest risk of getting breast cancer. So this is the next screening factor. If the conception was after 30 years of age, again, she's at a higher risk. So by this screening, we are able to know that whether this woman is at a higher risk or at a low risk. Now, what about breastfeeding? If she is breastfeeding her child, then again, she is at a lesser risk. But if the baby is bottle fed, then the woman is at a higher risk of breast cancer. Okay, unhealthy lifestyle. अभी तो सभी में बोलते हैं smoking, drinking, any other addiction, lack of exercise, right? Now we talk about this in relation to everything, whether it's hypertension, whether it's diabetes, metabolic syndrome, obesity. So it's true for breast cancer also. If the woman has chosen to have unhealthy lifestyle habits, then that also puts her at a higher risk of getting breast cancer. So you see, what are the modifiable risk factors, or what are the factors that we can change, or that we can, assist her to change? Obesity she can work on. Smoking, drinking is what she can stop. High fat diet is one more thing that can be regulated. So these are the modifiable risk factors that she can work on. But what are non-modifiable are? Age, gender, family history, all these changes, all these things you're not able to change, right? Early menopause, early menarche, late menopause, all this we cannot change. Increased breast density, chest irradiation during childhood, and this genetic mutation. These are non-modifiable and we can't help them, right? So this is as far as those screening is concerned. A lot of patients come to your OPD every day, and so you should be able to screen out if this patient is at a higher risk. So let's go ahead and do some other tests for her. And this particular patient is at a lower risk. That the screening helps you to come to that conclusion. But nowadays, when you start your practice, you will realize after a certain age, we advise mammography and other screening tests to all the women, right? And so then here comes the next part of our session, which is breast screening, right? Breast screening kaise karenge? So everybody's heard about self breast examination, Everybody knows about it, right? And so what are the commonest symptoms that, a patient can come to us with is new lumps in the breast or in the armpit. Very important. The armpit thing is very important. You have to keep an open eye, because even a lump in the armpit could be, a breast cancer. Any thickening, any swelling, any dimpling of the skin, any redness or flaky skin, nipple discharge of any kind, whether it's pus or blood or anything, change in size or shape, or pain or mastalgia should raise your concern. You can see most common, you'll see a lump or thickening in the breast, discharge or bleeding you will see, change in size or contours of the breast, redness or pitting of the skin over the breast, like the skin of an orange, change in color or appearance of areola, inversion of the nipples. So all these are symptoms that you might see in a breast cancer patient. And why screen for breast cancer universally? Because as true with all other cancers, if you screen at a timely interval, and if you're able to identify it, in the initial stages, obviously treatment is easier, and survival and prognosis is better. So even that's true for breast cancer as well. And so now you see there are all these American guidelines that are available even on Google. I can share the PPT with Neil and Anaga and Shivani if you all want. You can take it from them. And so these screenings are available, and they help us put the patient in a particular group. And you see the first one tells us about whether you need to emphasize the screening at 40 to 49 age or not. 50 to 75, what should you do? And more than 75, what should you do? The rule of thumb in today's practice is, if the woman is more than 40 years of age, she has to get at least one mammogram to begin with. Jaise 40 plus hai to mammogram. So we actually have a battery of tests that we get done if somebody just comes for a preventive service to me. So we will request her to get a pap smear, request her to get a mammography. So the rule of thumb is ye sab karna hi hai, along with the blood test. You do one PV examination, do one pap smear, do one mammography, so that if all the tests are normal, that forms as your baseline. If today she's 40 and if all her tests are good, it forms your baseline. So every 2 years, then you can see what's happening in her body. Right. And so a self-breast examination is important, should be taught. It's a very, very cost-effective method. Free mein ho jata hai na, self-breast examination. If you teach the woman, she can do it on her own. She doesn't need a doctor also. And if there are any changes, if she's finding any lump, etc., then she can come to you. So this has to be taught to all your patients. If she's 40 plus, mammography and annual mammography is the key. If it is high risk, then mammography plus MRI. And high risk, humne dekha pehle slides mein, what are the high risk causes. Now, what is self-breast examination? It's a very, very simple method. It is, the woman has to check her own breast during post-menstrual period and feel for any lumps or any changes. So as we saw in the other slide, क्या changes हो सकता है? Dimpling हो सकता है, redness हो सकता है, कुछ orange appearance, anything which is not seen before. जो भी कुछ अभी अलग दिख रहा है पहले से, that should be a clear-cut sign for further treatment, right? And self-breast examination should be started at the age of 20 years. Right. And so how do you do it? I'm sure you all have seen it in the OPD. And so if you are doing it, then the patient, it's a simple palpation method where you're just rotating your hands over the breast, including the axillary area, and you're trying to feel for any lump, any tenderness, any mastalgia. These are the different positions that the woman has to take, with her hands up, hands on her down, all those different postures she has to take. And the idea is to just move radially from the center to the outside borders to check for any abnormality. So that's about the self-breast examination. So, and clinical breast examination is done by doctors. It doesn't require any equipment, has to be done by hand, and look for any lump or any other changes. Regular clinical breast exams should be done for every woman who's more than 30 years of age. Now coming to mammography, right? Mammography is one very good method where we can find out any abnormality, and it is the option is to begin annual screening at the age of 40. Annually screen the woman with the mammography to see whether she has any abnormality or any changes in the breast. And what happens once she is beyond 70, then the guidelines are saying that we can stop the mammography, given the fact that if from 40 to 70, if everything is normal, then no need to repeat. This is the American Cancer Guideline of 2015. Ultrasonography, especially for young women, if you can see some solid cystic areas with dense breast tissue, then nowadays a ultrasonography or a sonomammography is also advised. MRI when is to be done only when both sono and mammography are inconclusive in average risk women and also for high risk women annually. So these are the screening methods that are to be used to see the breast, examine the breast, right from starting with self breast to clinical breast examination, to mammography, to sonomammography and MRI, right? And this particular slide tells us about the sensitivity, the specificity, the advantage of one over the another one. So all those points you all can go through the slide, right? And these are higher tests like breast scintigraph, breast ultrasonograph plus conventional mammography, 3D ultrasound, color Doppler, power Doppler, automated breast ultrasound, volume-based ultrasound. So once if the woman has been diagnosed, then this has to be done by the person who's taking care of her cancer. Then there is sonoelastography, MRI, and with CT scan, right? These are the screening methods of the breast. Now we are coming to biopsies. Biopsies are also needed to understand whether what kind of cancer it is. And the biopsies are of three different variations. Fine needle aspiration cytology, TrueCut or core biopsy, and lumpectomy. So now see, these are all taken care by the surgeon. There are specialist doctors now who take care of breast cancer patients. So either surgeons or even gynacs who've been trained in this will do all these procedures. So this was our basic screening methodology. And then how do we stage? This is very important. शायद आप लोग के एग्जाम में भी आएगा कि TNM staging क्या है. So this slide is important because this tells you how do you put the woman in stage 0, 1, 2A, 2B, 3A, 3B, 3C, and stage 4. So all of that depends on the tumor category, whether it is the size of the tumor, whether it is involving the nodes or not, and whether it is metastasized or not. So this TNM staging is the gold standard for staging breast cancer. Any questions till now? Anaga, any questions that they have?
No, ma'am, nothing as of now, and nothing from the YouTube live as well.
Okay. Let's go there now. And now we're coming to the genetic testing. Genetic testing, there are two particular mutations that we are worried about. One is BRCA1, the other one is BRCA2 mutation. So if there is a personal history of breast cancer plus diagnosed age of 45 years or younger, diagnosed age of less than 50 years with one or more close blood relatives with breast cancer at any age, even pancreatic cancer, prostate cancer, or unknown or limited family history, or diagnosed less than 60 years with a triple negative breast cancer. So now this is another method that is being used now, the genetic mutation testing, to understand whether the woman is at a higher risk or not. You all must have heard about a Hollywood actress who did this BRCA mutation testing, found that it was positive, had a family history, and then for radical mastectomy. Do you all know who that person is?
Angelina Jolie.
Yeah, I think people know.
Angelina Jolie.
Right. So now this is like a gray zone where whether even with this, agar ye bhi positive aa gaya and you're going for radical mastectomy is a gray zone which individuals have to decide. But the scientific point is that we do have this method which is available and which can tell us whether this person is at a higher risk or not. So this was all about the screening methods, starting with the high risk screening, then the breast screening, then we came to all those different sonomammographies, etc. And of course, the genetic screening. And then I began the presentation by saying that, gynecologists, we see ourselves as preventive oncologists. So we have few points that we always tell to our patients is maintain healthy weight throughout life, have healthy weight, food, limit sedentary lifestyle and be physically active, limit alcohol and smoking. Second point that we say, for preventing or for early identification of cancer, get screened at the age of 40 years or older or earlier if high risk, elicit history, in the family regarding cancer risks, detailed medical and family history has to be taken. If the patient is at a higher risk, then self-examination, clinical examination by 20 years herself, mammography, MRI to be done annually for 30 years onwards, and 5 years earlier, and even 5 years earlier if your relative has got cancer. So the topic of the session was, are we vigilant enough? And the answer to that, according to me, is we are not. We still have a long way to, to percolate this information in the general population. Even today when I get patients and, they are maybe all good literate patients and still they're not aware about all the screening methodologies. So if this is what we see in our day-to-day practice, I think we have a long way when we are working in government hospitals for the marginalized and for the poor patients. I'm sure there is a long way where we really will need more efforts in order to tell them about the screening methods, in order to there should be some more initiatives for them to know what are all the things that they can do for early detection. So that is the thing. I mean, as we know, the screening will really help us because we will be able to then identify cancer at an earlier stage and can provide adequate treatment. And so instead of waiting for government or other NGOs to work on, within our sector or within our area, whoever we are able to orient, we should do it ourselves. And we should utilize the opportunity where we can diagnose breast cancer at a very early stage and refer them timely and reduce morbidity and mortality related to breast cancer. So we have this opportunity with us. Let's make every woman aware, get this awareness, have the knowledge regarding breast cancer, teach them self-breast examination, let them come at proper time for their examinations for mammography, etc., and diagnose early and treat it. So this was all from me, Shivani, Anagha, and Neil. If anybody has questions, I would be happy to take them now.
I have the Dr. Bharadwaj in the chat box. However, I highly encourage our participants to use them or put them in the chat box. Also, if there are any types to manage.
Thank you so much, ma'am, and thank you, Shivani. So for those who are viewing online through the YouTube live, can join in through the Zoom meeting link, which was shared earlier in the mail. The same email ID through which you had registered, so that we'll be sharing the post-webinar link in the chat section here in Zoom. There is no cap on the number of participants that has been removed, so you can join in and start accessing the post-webinar form. And meanwhile, those who have questions, which is directed to ma'am, please put it down in the chat section so that ma'am can start taking all these questions.
Ma'am, we have one question. Is early menarche, which we recognize to be a risk factor for breast cancer, preventable?
No, menarche is not in anybody's control, and it is not a good idea to deal with a young adolescent or a young person with any form of hormones or any other treatment. So menarche is not really menarche is also familial or hereditary in nature, so we cannot play with that, right? And we do see early menarche nowadays because of various factors. One being obesity and sedentary lifestyle again, and because of COVID and girls have, we are seeing a lot of girls getting in early menarche. So one thing to prevent or to maybe take care is to have a healthy lifestyle again, is to have like do exercise, maintain a healthy weight, good diet, etc. Obesity leads to early menarche in many of the cases.
Inesh, you have your hand raised. You can unmute and ask your question.
Hi, am I audible?
Yes, you are.
Good evening, ma'am. I'm Ines from KMC Manipal. Thank you so much for your session. I had this one small query. During the beginning of the session, you mentioned about how history of breast cancer from the maternal side is also one of the risk factors of breast cancers being caused in the child. But we also do read that males also do get breast cancer. So history of breast cancer amongst fathers or in the paternal side, does it also contribute to breast cancer?
So when I mentioned about the breast cancer higher from the maternal side, I was specifically talking about breast cancer in females. So within the female subgroup of breast cancer, the chances of her getting, so it's not that all people who had a family history of breast cancer will get cancer. It's not that. We were only trying to say that women who have cancer history in their family, in their maternal side, will have a higher chance, or when you screen them, would be at a higher risk of getting cancer, breast cancer.
Can that also come from the father's side? Because
No,
breast
not
cancer,
from the paternal. For that particular woman, it is more from the maternal lineage. So we, even when in history taking, हम लोग पूछते हैं आपकी sister को, mother को, grandmother को. So we always ask from the maternal lineage.
okay, thank you, ma'am.
We have one more question. What would you say is the best screening modality for breast cancer?
Okay, so see, different age groups, it would be different, right? For a younger age group, self-breast examination, clinical breast examination would be a good screening method. But then a woman who is more than 40 plus, for her, a mammogram is the best screening modality. Anyway, she has to do a mammogram after 40 as a screening method. But for a younger patient, 20, 25, 30, they can do a breast examination, self-breast examination, and see if they're at a higher risk or not.
There is one more.
I can see one more. I am also reading it. Yeah.
How to approach and spread awareness about breast cancer detection in Orthodox families in India who are not ready to talk openly about it.
Yeah, so this is like a societal issue, and this is the social problem that we have in our family, in our country. But then see, we do get opportunities of interacting with these people also, right? And so I mean, I am talking about now one-to-one in a clinical practice, where you do get opportunities of talking to these young girls, because there is an opportunity where they come to us for Gardasil and Cervarix vaccine to prevent cervical cancer. You have to make use of these opportunities to explain to them other preventive methods, right? So that one-to-one basis is what I'm talking about, clinical practice. But if you're talking about a public health, if you're talking on a public health perspective, then certain programs and certain initiatives will have to be designed in and around these adolescents. So whether we give this information to them via school programs, where I still remember, when we were in school, there were sessions on menstrual health and menstrual hygiene. Maybe we can integrate this within the school programs and use those opportunities. So there are two different answers. One is for the clinical side, one-to-one practice, and for public health sector, we will have to devise programs and we'll have to find opportune times. Then I see there are thermographies used for breast cancer, thermal scanning related to breast cancer. So see, Aryan, these are all higher modalities of treatment. And as I said, even during the lecture, I said there are special breast surgeons and special breast cancer doctors now. So even in my practice, my role is to just diagnose, I diagnose it at the right time, and then I do refer them for all these higher methods that you are talking about. Right? Endometriosis also have a higher risk of breast cancer? No. So these are two different diseases, endometriosis and breast cancer. So there is no link. But there is a link between longer duration of OC pill intake and breast cancer. So you really have to weigh family planning, OC pill method, and you have to continuously, if a patient is on a OC pill for a longer duration, then mammography has to be done continuously to ensure breast health. Again, I read a question about earlier girls get knowledge about sex education, menstruation, and early menarche. So that's what I said, that if we have to raise awareness in general population on a bigger or a scalable place, then we have to get these girls within the school atmosphere, where they do invite gynecologists, they do invite doctors to talk about menstrual health, menstrual hygiene, how to use a pad, etc. And we can integrate it. In fact, we can integrate the Gardasil, this cervical cancer prevention vaccine, plus cell breast examination as two initiatives within that program. Right. Oh, exposure to X-ray, irradiation exposure have a higher risk. That was in the PPT also.
Ma'am, there is one question which I got direct message. Is family history of prostate cancer related to breast cancer risk? If so, how?
No, so prostate cancer again has more bearing on breast cancer. Another thing, PCOS, PCOD increasing risk of breast cancer, not so far we are not aware. PCOS, PCOD are different conditions related to ovaries, so that don't really have not seen leading to an increase in the breast cancer. Yeah.
Higher estrogen level, though has a direct relation to...
Yeah. Anirudh, higher estrogen level does have a direct, but that is not the only factor that will cause breast cancer. No? So if you are correlating it with endometriosis or PCOS, PCOD, so not all PCOS, PCOD patients are going to get a cancer, breast cancer. So no, these are different ailments.
Ma'am, there is one more question. Does OCP treatment for PCOS increase the risk of breast cancer?
No, see, even if you're giving OCP for a PCOS patient, it's not going to be a lifelong treatment, right? You are going to use the OCP in a very regulated manner. A longer duration of use of OCP for family planning method, once contraceptive, instead of using any other contraception, if a woman uses OCP, then that could lead to breast cancer. That is the reason why I said when we use OC pill, we make sure that we get all these screening tests done regularly, so that the cancer risk is not there. Yeah, again the same thing. HRT again is to be used in a very regulated manner. It does have estrogen, it does have progesterone. Estrogen in HRT is very, very minuscule. 0.0001% of estradiol that is there. Any kind of treatment, any kind of hormone that we are giving to a woman, we will have to do a lot of screening by the way of these mammograms and all these various tests that I explained.
Ma'am, another question from YouTube. How often should a woman do mammogram post 40 years of age?
So ideally, annually is the best answer. Liver disease, a risk factor, breast cancer in men, not that I know of. And I studied more about breast cancer in women. Okay.
There are no more questions, ma'am. I'll if I have your permission, I'll just display the post-webinar questionnaire and we can keep having questions alongside.
I think meanwhile we can have a picture. So ma'am, with your permission, I think we can go ahead and
Yes, please.
I request all the attendees to turn on your cameras.